Coming up on our Mother's Day program, stories of strength, resilience, and healing. From supporting new military moms navigating motherhood far from home to the inspiring journey of stroke survivors reclaiming life. This episode is a tribute to the power of support when it matters most.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at AmericanBrainFoundation.org. Rethreaded knows human trafficking destroys lives, but they also know it's not the end of the story. Rethreaded believes in the potential and power of all survivors to reclaim their lives. Visit rethreaded.com to learn more. And Elevate Med. Through mentorship, leadership development, financial literacy, a robust peer network, and tuition-based scholarship support, Elevate Med is dedicated to the next generation of diverse physician leaders as a tangible step towards the eradication of health disparities. More at elevatemed.org.
From the moment we're born to our last breath, every American embarks on a journey through the intricate maze of the healthcare system. These are their stories, one life at a time. Today we meet Sergeant Maria. Newly stationed far from home and pregnant with her first child, she began having trouble sleeping. She cried easily and felt constantly overwhelmed. She worried she wasn't bonding with her baby and avoided medical appointments, fearing judgment. Her partner was deployed, and she felt isolated. When she finally opened up to a visiting nurse, the diagnosis became clear. Hi, I'm Dr. Joe Sirven, a practicing neurologist at Mayo Clinic and professor of healthcare administration and policy at Arizona State University. This is What's Health Got to Do with It, which looks at where and how healthcare intersects with your life, helping you get the medical answers you want. Now let's turn our attention back to Sergeant Maria. The diagnosis? Postpartum depression. And joining us now is retired U.S. Navy Captain Rosemary Perdue. She's director of the Visiting Nurse Program for the Navy Marine Corps Relief Society. She is piloting a first-year program, the very one that helps military moms like Sergeant Maria, whose story opened our show. Captain Perdue shares how this initiative brings compassion, connection, and critical care to both expectant and new military moms, changing lives in powerful and unexpected ways. We thought this is a perfect topic for our Mother's Day show, and she joins us now. Captain Perdue, Rosemary, welcome to our program.
Well, thank you so much for having me.
It's so good to have you here. You just heard the story of Sergeant Maria, and I'm wondering, when you hear that, how common is her experience among military moms?
Well, Sergeant Maria's story is actually something very common and something our visiting nurses see quite often. Actually, 1 in 3 mothers in the military community will experience a maternal mental health condition. And our Navy Marine Corps Relief Society visiting nurses, they're all registered nurses, and they serve 21 sites globally and include isolated areas overseas and locations that also have a high operation and deployment tempo. So this happens quite more than you would think.
Wow. What signs should families and friends look for in a situation like Sergeant Maria? What should be those telltale signs that maybe they need help?
Actually, if they look and see for any changes in a loved one's baseline behavior, so something just doesn't feel right. They may have feelings of sadness or anger, hopelessness, anything that raises your antennas about your loved one. You may see them withdraw from social activities, have trouble bonding with their baby, and any changes dramatically, like in appetite or sleep. So when I say sleep, it's hard with a newborn, of course, but an inability to sleep when given the chance.
Mm.
And then most importantly, they may also have intrusive thoughts, something really anxiety provoking that they just can't get out of their mind. Maybe some exaggerated fears. I'm fearing I'm going to drop the baby, or something's terrible's about to happen. These are really things that any family or friend could look out for. And if they see these, they could ask for help. There's lots of resources, and there's definitely interventions to help get them back on track.
So I'm curious, what inspired the creation of this pilot program of the First Year Focus? And tell us how that's different from other maternal health efforts in the military.
Absolutely. So Navy Marine Corps Relief Society's Visiting Nurse Program has been around for 102 years. So
Wow,
our nurses.
that's a long
Yes,
time. I did not know that.
yes. So we've been around quite some time. We know military communities very well. Our nurses are incredibly knowledgeable about maternal health, unique challenges of military life, and they're experts in finding community resources that can help our families. And as I mentioned before, the 1 in 3 military families that are affected by maternal mental health conditions, and this is twice as prevalent as our civilian counterparts.
Mm,
So, in light of this alarming maternal morbidity and mortality crisis that our mothers are facing in the United States, we really felt like our program was well poised to have an impact in the program. And that's why we developed First Year Focus. Our care differs from others as our registered nurses focus on health education, the local resources that they can give referrals, and addressing individual needs of each of the patients and tailor those services to meet the needs. We don't duplicate services that are on these military bases, but rather we fill gaps.
I
So I
see.
believe that's how we differ.
I see. You brought this up in terms of where your group is located and helping moms all over the globe, it sounds like. How
Yes.
a comment, talk to us a little bit about military life. We know there's a lot of moves, there's a lot of deployments, there's
Yeah.
isolation depending on certain locations. How does that uniquely impact mental health of new and or expecting moms?
Well, that's a great question. Moving every few years can interrupt prenatal, postpartum, or pediatric care, and it also can make it difficult to build trust with healthcare providers or maintain a consistent mental health support. Each move often means leaving behind established support systems like friends or families, a mom group, and that leads to isolation and loneliness and disconnection. The logistics of relocations, especially during pregnancy or with newborn care, can exacerbate anxiety and can contribute to emotional fatigue. And then adding a partner being deployed, the new and expectant mother may experience significant stress or burnout managing everything alone. You can imagine.
Sure. You talked about trust. I'm going to hold on to that word. This is a cornerstone because you are trying to build trust quickly with these moms. How do you go about doing that, especially if the person feels alone or overwhelmed?
Right, great question. Well, our visiting nurses offer frequent one-on-one care in the comfort of a patient's home. So we don't have the typical time constraints of like a clinical visit. So we start building relationships with them during pregnancy, and we continue for the first year of their baby's life, which evidence shows that it's a particularly vulnerable time for new parents. So we really can get good baselines, we can understand their needs and their unique stories as a military family. Our nurses connect with patients' local resources with their community and help them also build a support system, which is very helpful.
Mm. I want you to walk us through a typical day for a visiting nurse supporting a new mom in this program, and comment: are these nurses, are they in the military as well, or are they both civilian and military? Walk us through that typical day of what that would look like.
Oh, sure. So our nurses are civilians. They
Okay.
are not part of the military
Okay.
system. So we help enhance. Our home visits are the hallmark or special sauce, I like to say, of our program. These visits can look very different according to the needs of our patients. So there's rarely a typical day. But if you would often find our patients are requested infant feeding support or growth monitoring, the nurses are screening for postpartum mood and anxiety issues, connecting them with the patients with, needed resources. You may find our nurses rounding up the hospital
Hmm.
at a local military treatment facility. With the patient's permission, they can even collaborate with healthcare providers to ensure patients aren't falling through the cracks. And then some of our nurses in other locations that aren't having the classes or support groups in their area, they offer the class and support groups. So it's actually finding that need and filling that gap.
I'm wondering how would it work? You talked about you are Lily Global. If that military mom is in a very difficult location, deployed, something along those lines, where you're on foreign land or something like that. Um, how does that work in that scenario?
Well, we also have a virtual component
Okay. Okay.
that you can reach out to us also with our visiting nurses. But right, we're not everywhere.
Okay.
We
Fair enough.
certainly
Fair enough.
would love to be, but we do have some other components of our programs that we can offer virtually if needed. Did that answer your question?
I think it did. I think the main thing is that if in those scenarios, if I understood it right, where you can't be there, you do have a virtual element that you could do almost like a televisit, if you will.
Yes, exactly.
I'm wondering if you can also comment a little bit about how does this program, at least the one you're piloting, how will that help strengthen the bond between mother and baby even before that baby arrives?
Right. Well, that's the exact reason why we want to get in early and be proactive. If we educate patients at a time when they're better able to absorb that information, they're not sleep deprived or overwhelmed with a newborn, we can equip them with the tools necessary to navigate perhaps those more stressful situations ahead of time. And when the situations do arise, if they do, they don't feel so alone. They feel like they have a nurse to turn to or someone they're equipped with some knowledge of risk factors and how to seek help. So by taking some of that weight off their shoulders, it allows them to spend more time with their to bond with their baby.
To all of our listeners out there, you're listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Sirven, and if you're just joining us, we're in conversation with retired Naval Captain Rosemary Perdue and her work in helping new moms in the military. And we want to hear from you. Tag us on social media at JServin. Rosemary, what are some of the most common physical or mental health issues that the program helps to catch early? And why is that early detection so critical?
I would say the most common health issues we're able to catch in the home are hypertension and perinatal mood and anxiety issues.
Okay.
And we're able to educate the patients to know what to look out for and how to seek care from a provider. For infants, our most common findings include feeding difficulty and growth concern.
Hmm.
We see more tears from our moms from low weight gain than anything else. So
Really?
yes. And so we can collaborate with providers to track growth and help create a plan for any necessary nursing interventions, let's say between pediatric visits, for instance. And you mentioned early detection. Early detection is essential as it allows us to obtain treatment before issues become critical.
I This is a healthcare show, and I often have to ask always that always touchy subject of money, price, or access. Is this free? Is this something that has to be
Yeah.
paid for? How does that work?
Yes, we're absolutely free, but we work from donated funding, but we can offer free HIPAA compliance services at the bases that we're at. And then, like we said, we also have the virtual option.
We produce this show from Jacksonville. We have a lot of military bases in and around us, particularly in the Navy and other branches. For listeners who are outside of the military, what can we learn from this program about supporting moms in our own communities? What does it teach the non-military or civilian folks, if you will, about what needs to be done, period?
I think we just need to ask, how's mom doing? And then listen.
Yes, I love it.
You know, I mean, so many times you see that cute little baby and everybody makes a big fuss, but it really opens the door for honesty. New moms may be struggling, but feel pressure to say things are really going great. But if you ask directly, you can give space to share how she's really doing. And, if you think about it, they just went through such a major physical, emotional and psychological shift. So if you center her and acknowledge that, it reminds her that she matters too. And a mother's recovery, mental health, and support system directly influences how she bonds and cares for her newborn. So shifting that focus to mom really helps normalize the fact that postpartum care is just as vital as newborn care.
So important. Is there a story or moment from your work that really has stuck with you, and maybe one that our listeners out there who are trying to understand your work, that really captures the heart of what this is all about?
Dr. Sirven, I wish I had time to share all the
But we have
powerful
a few. We have plenty of time right now.
I wish I had time to share all the powerful stories of how our visiting nurses made an impact on mothers through the years. But some that stick out in my mind is we have infants who were hospitalized after one of our nurses found a critical case of jaundice during a home visit. And as you know, that could have been extremely serious. Another one of our nurses found 4 pregnant patients in 1 month that unknowingly had hypertension just through routine blood pressure monitoring.
Wow.
And she was able to link that patient up with their provider, and they could get a proper medical diagnosis and treatment. And there's been numerous times when a nurse identifies a patient struggling with postpartum mood, or like a mood disorder or anxiety, and they're able to swiftly connect them with treatment and resources. So those are few things that stick out to in my mind when you ask about our impact.
What about, I know this is all about moms, but I'll ask it just to be complete. Like, what about dads?
Yes.
I know it's different, but does the work also involve dads as well?
Absolutely. This is a family business. So we
Fair enough.
absolutely include our dads. They're very much part of our teaching. They're very much part of the treatment plans and what we need to move forward. So most definitely our dads are included and always welcomed. And, studies have shown that dads' involvement has better maternal health outcomes down the line. So it's very important to include our dads or any spouse or significant other who's in the family unit.
I know that within the title of the program, they call it for the first year focus program. At least that's what's being piloted. So a very logistical question is, does this end at exactly 1 year from birth? How does that transition at the end of the first year work, or what happens after that?
Well, that's a great question. Well, we're hoping to take what we learned from the pilot and expand it to more areas in the near future, but we want to get some great feedback from patients. So we're only a month in for the pilot.
Yeah.
We're currently piloting first year focus in Great Lakes, Groton, Connecticut, and Portsmouth, Virginia.
Okay.
And so we're closely monitoring with the nurses as well as the patients, but we would like to use, the patient as our guide. Are we getting this right, or do we have the correct information? Were the handouts appropriate? Was it enough time? So I think for now we're just we're getting through some of the structured visits that we've put in place, and then we're going to watch. And we wanted to add enough flexibility in there. So if a patient requires more, or the nurse feels like the patient could benefit more for continuing the program, then that would be okay also.
Rosemary, I know you have served in the military. You're helping to work with these military families. And I'm wondering if you could just address this question, which is, what do we as civilians listening out there not know about what it's like to become a parent, a mom in the military that we just don't appreciate? How would you answer that?
Wow. Well, it's very demanding. I've actually done it myself
Oh,
a couple
wow.
times.
Wow. So
in my 30 years of being in the military, I've had 2 children. I've actually had an active duty husband at the same time. So
Wow.
very familiar with how it is. And I mean, things have changed. My children are older now, but it definitely can be demanding. I
Got
wish
it.
I knew about the visiting nurse program when I was going through, because I really could have used somebody to call on
I see.
during those times. So what we can do is really just all of our programs are free of charge to military families, which is made possible by our generous donors. And the best way to support our programs through spreading the word about our services. And of course, if you would like to donate, you can go to www.Navy Marine Corps Relief Society. It's nmcrs.org to donate, so we can get help that these military families so desperately need.
In our final moment here, I want to give this opportunity to you, Rosemary, to basically send a message of a Mother's Day message, if you will, with regards to your organization or to all of our listeners, given that it is Mother's Day weekend.
Well, happy Mother's Day to everybody out there. And I hope you call us if you would like to engage with our nurses. We do have a nurse in the Jacksonville area, which is fabulous. And we have 25 nurses poised around the globe that are here to help. And if you want to contact us at the Visiting Nurse Program, we'd love to hear from you at visitingnurse@nmcrs.org. I'd love to hear your thoughts and hear more about what we can do, but we're here for you. I guess that's the message that I'd like to leave with you, is that Navy Marine Corps Relief Society and the Visiting Nurse Program is here for you, and you have a fabulous Happy Mother's Day.
I can't say it better myself. Rosemary, thank you so very much for your work and for joining us today. This has been fantastic. I hope you get a lot of supporters today.
Thank you so much.
We've been talking to retired Captain Rosemary Perdue. She's director of the Visiting Nurse Program for the Navy Marine Corps Relief Society, and she's piloting a program on the First Year Focus program that looks to help new and expectant moms. Up next, after your weekly health headlines, we continue our focus on healing through hardships by focusing on stroke survivors. And we'll be right back. Hey, it's Dr. Joe Sirven. I have a new show called This Week in Health, and it's part of WJCT News Now. Local news you can listen to anytime, anywhere. When you sign up, you'll unlock 4 local podcasts delivered straight to your podcast app. I break down the week's biggest health headlines and what they mean for you. Start a free 30-day trial at wjct.org/newsnow. And if you like it, become a monthly donor to support WJCT Public Media.
Hi, I'm Stacey Bennett, producer of What's Health Got to Do with It, and these are your weekly health headlines. As of this week, the United States has reported 935 confirmed measles cases across 30 jurisdictions, marking the highest annual total since 2019. This surge represents a significant increase from the 285 cases reported in all of 2024. The outbreak is particularly severe in Texas, which has recorded 663 cases, mainly concentrated in the Northwest region. Experts warn that if the current trend continues, Texas could surpass 1,000 cases by early summer, making it the state's largest outbreak in over 30 years. The CDC has reported 216 pediatric deaths due to influenza this flu season, marking the highest number since the 2010 H1N1 pandemic. This surpasses the 207 pediatric deaths reported last year, and with the flu season still ongoing, the final count is expected to increase. Experts attribute the rise to declining flu vaccination rates among children, which have dropped from approximately 64% 5 years ago to about 50% this season. The unsupervised use of psilocybin is up among all age groups in the U.S., but especially in adolescents and adults under 30. According to a new study published in the Annals of Internal Medicine, the use of magic mushrooms among adults in 2023 was higher than estimates for cocaine, illicit opioids, methamphetamine, and LSD. Although some clinical trials indicate psychedelics show promise in treating conditions like depression, anxiety, substance use, and PTSD, psilocybin leads to hallucinations, and users can become a danger to themselves or others. Finally, a new report has revealed thermal receipt paper in the U.S. contains dangerously high levels of bisphenol S, a chemical linked to cancer and reproductive issues. The chemical is used to coat receipt paper and can be absorbed through the skin in just seconds. The nonprofit Center for Environmental Health has issued legal notices to 50 companies, including AMC Theaters, Dollar General, and Burger King, demanded they eliminate bisphenol S from their receipts or caution customers about its toxicity. To protect public health, businesses are being urged to adopt safer alternatives, such as vitamin C-based thermal paper. And those are your weekly health headlines.
Welcome back to What's Health Got to Do with It? I'm Dr. Joe Sirven, and on this Mother's Day, we continue with a look at healing through hardships. Let's meet Shannon. Now, during a Sunday brunch, Shannon, a 62-year-old mother, suddenly dropped her fork. Her speech slurred, and the right side of her face drooped. Her daughter, recognizing the signs, called 911 immediately. In minutes, a specialized team was mobilized. Thanks to rapid intervention and advanced treatment, this mom got a second chance. What medical emergency nearly stole Mother's Day and her future? What's the likely diagnosis? The answer is an acute stroke. For this mother, fast action and expert care made all the difference. But surviving a stroke is just the beginning of the journey. From emergency surgery to long-term brain recovery, stroke survivorship involves a delicate balance of science, support, and resilience. To help us work through this entire scenario and look at this topic are Dr. Robbie Talk. He is a neurosurgeon at Mayo Clinic here in Florida.
Thank you, Joe, for having me.
And Dr. Michelle Lynn. She's a neurologist also at Mayo Clinic here in Florida. Thanks so much for joining us.
Thank you so much, Joe. It is always fantastic to be on your show.
We love having you both on. We know you're both vets of this show, so we're going to enjoy having you both here in person. Dr. Tuck, I'm going to start with you. You just heard the story of Shannon. She has the daughter brings her in, smartly recognizing symptoms quickly. But I'm gonna start with you because we often think of the medical intervention, but we don't often think of the surgical intervention. And I want to ask how you can help us figure out whether a stroke patient needs to have immediate surgery versus going to some other clot busting.
A great question, Joe. So the first thing that we think about is the type of stroke. You have two types of strokes. The first one is ischemic stroke, most commonly caused by blockage of a vessel. And the other one is hemorrhagic stroke, when there is bleeding. And the type of intervention depends on, which one it is. The second factor is imaging, and imaging is key for stroke. A CAT scan most often determines if you have a bleed, and you do it very quickly, and it's available at every institution. And if it's not a bleed, most of the time it must be an ischemic when the vessel blocks down. Now, for ischemic stroke, when surgery is considered, is you want to think about removing the clot, and what we call thrombectomy in the medical language. And it's used when a large artery is blocked. And here time is of the essence, because you want to do it as fast as possible. And not every stroke, you're absolutely right, not every stroke needs surgery. Some of them are resolved with a clot busting medication, which is available in almost every hospital. The bleeding stroke, hemorrhagic stroke, is a little bit different, and it depends on the cause. If it's just bleeding from a weak vessel, or if it's an aneurysm, which is a weak vessel, but sometimes the cause could be from a very tiny vessel bleeding, or a larger vessel bleeding, or a vascular malformation. A little bit more complex decision, but that's how we decide based on the imaging. And the other factors influence the decision is where is the bleeding, where is the stroke, how much it's affecting the patient, what patient characteristics, their age, their overall health, how much is the stroke affecting their lifetime? Are they on blood thinners or no blood thinners? And the last one I would like to talk about is the multidisciplinary approach, where you have other specialists pulling their decision into the team, the anesthesia team, neurology team, ER team, and all these specialists. And everybody has a common goal, is to preserve brain function, prevent complications, and improve the long-term outcomes for those patients.
Let me follow up on that. Given that there's a multidisciplinary team, we have you here as a nurse surgeon, we have Dr. Lynn here as a neurologist. Who gets to make the call in a scenario between we're going to go down clot busting, if you will, with medication versus we can go at this from a surgical end? How does that work?
So nowadays we're working in a very expedited fashion that everybody is on the same team, and honestly, and all these are the hands and legs working together for the body to make the decision of stroke. So everybody weighs in, whoever sees the image first, whoever knows about the patient. Some people are examining, some people are reviewing the images, and we're using AI and app. We might touch base later, but
right.
Everybody is one unit. And instead of people deciding separately.
Got it. Okay, that makes me, at least that clears that up for me. Dr. Lynn, we often talk about prevention of stroke and what happens during a stroke. We don't often talk about the other side of it. And so I'm wondering, what does a recovery journey, like in this case with the patient we just heard, look like for someone like that? And how soon does rehabilitation begin?
That's a great question. And similar to the acute stroke, it takes a multidisciplinary team of providers. In acute stroke, similar to how there's neurosurgeon, anesthesiologist, stroke neurologist, and after the acute phase of a stroke, after the patient get the IV to neck place, or if it were to be a ischemic stroke from a large vessel occlusion after the thrombectomy, the timing of rehabilitation starts early. So as long as the patient is medically clear, and early mobilization is encouraged, and usually about 24 to 48 hours after an acute stroke, that it is encouraged during the acute phase of the recovery, which the team would include a physical therapist, occupational therapist, and physiatrists, absolutely. And of course, that there's always a speech and cognitive component as well. So speech therapists to make sure the patient can swallow okay and cognitive recovery. So that's really kind of the acute phase, early mobilization. Now, the next step would be more of a subacute. It can be days to weeks to early months after the stroke. There is this golden stroke recovery period. It's usually up to 6 months.
6 months.
After the stroke, in which the rate of recovery is the fastest. However, stroke recovery continues after years, even up to a decade
Oh, wow.
after the stroke. Often after the patient discharged from the hospital, they will go to an acute inpatient rehabilitation, in which that they will focus on at least 3 hours of dedicated working with a physical therapist, occupational therapist, cognitive specialist, speech therapist, at least 3 hours to really kind of stimulate the brain such that the new synapse would be made. So the part of the brain that has not been infarcted from the stroke or bleed will start to make early connections.
I see.
Again, it's the fastest rate of progression. But now, moving on to the chronic phase, there are tremendous clinical trials that are ongoing currently, in which that we classically think that it is just the first 6 months is the golden period and then it stops. But we know now that's not true. And there are, things like vagus nerve stimulation, for instance, that enroll patients up to 10 years
After a stroke?
after the stroke. That's right, in which that stroke recovery continues. So like acute stroke, there are different phases. So I think the take-home message is that it starts early, as soon as you can. As soon as when the patient is medically clear.
Sure.
But it continues, and it is an ongoing process because of the neuroplasticity after the stroke.
I love that. I love hearing that there's this long period. Dr. Tuck, I'm going to go back to the realm of surgery with you. Again, once upon a time, we just didn't do a lot of surgical intervention in these scenarios, and now that can be a critical piece to this. I know you talked about if someone's bleeding or if there's an aneurysm, but how has surgery evolved, if you will, or surgical techniques or interventional techniques evolved to treat an acute stroke emergency?
So first you have to understand, what happens when a large vessel shuts down. What happens is that you have a cutoff of oxygen and nutrients to this large vessel. So within minutes, the brain cells start dying. So time is brain, and this leads to severe disability or death if you don't do anything. And we know about those patients, and the key here is now just to push and get this patient to what they need as fast as possible, which is opening the vessel. So let's talk a little bit about past versus now. I mean, the day when I was in training, stroke was a death sentence. You know you're going to end up in a nursing home. Yeah. But now, when Dr. Brott and colleagues, one of them is at Mayo with us, when they, showed up that TPA does work, the clot busting medication. Back then, we're exposing the whole body to this clot busting medication to work on a tiny vessel in the brain. Okay. So you had limited options, but now there is a game-changing technique, which is called the mechanical thrombectomy, where you thread a catheter into the brain vessels through an artery, usually the wrist or the groin.
Right.
And it's a tiny device that you use at the tip with an aspiration catheter or something, with the goal to take the clot out and restore the blood flow directly to the brain. And why thrombectomy is a breakthrough? Because it can dramatically reduce disability if done quickly, especially effective for large vessel occlusion because you have a target vessel, and these are the most dangerous strokes. And success rate and outcomes continue to get better and better with these tools. So technology continues to evolve, newer devices, Imaging techniques are getting better and better. Softwares, teams working together, AI tools, mobile stroke units. So we have so many things. And the big picture is large vessel strokes are serious, but we can now have powerful tools to fight back. The key is rapid recognition, specialized stroke centers, and team based care. And today, patients who once had little hope can walk out of the hospital.
I love that. And to all of our listeners out there, you're listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Sirven. And if you're just joining us, we are talking about stroke survival and prevention. And we want to hear from you. Tag us on social media at JServin. Dr. Lynn, when someone's had a stroke and they are in that process of survival, I imagine the first thought is getting back to normal, but the second one is, I don't want to have this ever again. How do you lower the risk of a stroke happening again in someone who's had one?
Yes, I think that's a very common question raised by our stroke survivors, like Shannon's mom, for instance. And it is key to really identify why is it that the patient had a stroke. Is it because of the disease of the heart, such as atrial fibrillation or heart failure? Or is it a large vessel disease, stroke, such as a carotid stenosis, or moya disease, large vessel vasculopathy? Because of the treatment for the prevention of stroke is incredibly different depending on why is it and where the stroke is coming from. For instance, going back to those with atrial fibrillation, for instance, the patient needs to be on oral anticoagulant, for instance. And that will be really quite different, from those with carotid stenosis, in which I need to refer the patient to a neurosurgeon like Dr. Tog. So the carotid can get revascularized, for instance. And now that even, with the new devices and technology, for those who cannot, tolerate blood thinner, for instance, there are technology in which we can occlude the appendage of the heart, for instance, such that the patient does not need to be on long-term anticoagulation due to the risk of bleeding, GI bleeding. And of course, that there are other, preventative measures. And the most important things is that stroke is highly preventable. Often it is increased the risk is due to the vascular risk factors, and such as high blood pressure, diabetes, higher cholesterol, obesity, smoking, sedentary life, and also unhealthy diet. So 80% of the time, the stroke can be prevented if the vascular risk factors, can be optimized and controlled. So often we kind of counseled about the importance of exercise at least 30 minutes per day, moderate to intense. Mediterranean diet is the diet of choice for healthy brain, and other measures.
I love that. I like that 80% statistic you just threw out there. Dr. Tuck, we talk a lot on this show about AI and advances in AI, and I'm wondering, I imagine stroke is just as impacted as any other medical condition. What can you tell us about its role, or what the evolution of those tools as it pertains to your part in the care of these patients?
Well, Joe, technology is a game changer in stroke care. Today's stroke care is powered by high-speed imaging, smart softwares, and these tools help us see the brain in real time, identify blockage, decide who can benefit from treatment even hours after a stroke begins. So you use those tools to decide what to do. If you look further into it, there's now apps where the whole team knows, and then you can track even the ambulance while on the way to the hospital to know
Wow.
when did the patient land.
So you see the clot in person?
Well, there are ambulance equipped with imaging, so you
Oh.
can start imaging while the patient coming to the hospital.
Wow.
You can relay and get an exam remotely on the patient, so the team knows how the patient is doing by the time they come to the hospital.
Amazing.
So by the time you're ready to go, and so you're informed upfront on this patient, and you're way ahead of the game. And advanced imaging does make a big difference. AI and all these tools, I mean, they're streamlined. They minimize the inefficiency, and they use all and they coordinate. It's almost like an orchestra, and you have somebody coordinating everybody to be on the same pitch and same page. And so AI is here to stay, and the good use of it is stroke is the best examples for the good use of it. The remote access to telemedicine as well is, you don't have advanced expertise at every hospital or every center, and you have those patients they live everywhere, and you
Sure.
got to take care of all the population. So
Sure.
that's where the AI comes handy to know what's going on and remote tele manage those patients. The bottom line, imaging and AI, they don't replace doctors, but they make them faster, more accurate, and more effective. So thanks to all these tools, more people are walking out of the hospital with their lives and independence intact nowadays.
I love that. That serves as a perfect question to lead into you, Dr. Lin, and our as we get to the final set of questions for us. Here we're talking about survivorship, or at least highlighting that part. How do we help patients in that journey? Maybe they have a language problem or a cognitive issue. How does that look like, that helping that emotional journey, if you will, from just this trauma?
Yeah, so a great question. Often the patient, came in with acute stroke, and they survive. And due to the advances in the technology, telestroke that really kind of bring the doctors closer, the expertise closer to the patient, and often after the stroke, we typically think of motor dysfunctions. The patient may not be able to move their arms or may not be able to walk well. We do have stroke recovery clinic dedicated, and it's multidisciplinary. So there is the physiatrist who really kind of specializes in rehabilitation, our occupational therapy partners, speech therapy partners, in which that really kind of focus on the cognitive and the emotional domains. We know that I just had a patient earlier today who was incredibly frustrated because of the language deficit. And of course, the caregiver, can also get impacted because 1 in 4, 3 or 4 of the stroke survivor would have some kind of emotional response or cognitive impairment, from it. So it's important to address not just the patient, to say that it is common, it's not just you. And there are, cognitive behavioral therapy, there are medications, and at this particular time point for those with motor dysfunction, there's this FDA-approved, device called vagus nerve stimulation device. Can be used up to 10 years after stroke. And how it works is just really kind of works and augmenting the neuromodulation, improve the neurochemicals such as acetylcholine, norepinephrine, and that really augment the recovery process. And I've had so many patients, who had undergone, the vagus nerve stimulation, partnering with our neurosurgeon, as well, that they're just so excited that, they can be able to ride again, and that is really a tremendous joy to the patient and, of course, their caregivers.
I love hearing that there's something available that way. In our final moment, Dr. Tak, I know there's an event coming up at Mayo Clinic. I wonder if you could kind of comment on that for our listeners who may be interested.
Absolutely. So the event is geared to meet with patients, not just when they have a stroke. It's a group. It's a big group, but not only for patients or doctors, for the whole team. So we dedicate one day where we sit down together, from doctors, techs, nurses, staff, with patients, their families, rehab, the whole spectrum and the whole team, sitting down one day to say, we're here together with the patients, with their families, taking this fight because there is a brighter future. So the event is May 3rd at Mayo Clinic, and we welcome everybody, although the space is limited. So we have a website, basically, and it's going to be shared via Zoom, because those things are very powerful, and we got to use technology to disseminate the message to improve stroke awareness. And we want to tell patients we're against stroke for you, and we want to, on Mother's Day, we want to bring every mom back to her family, and we want to bring every family back to their mom with the best outcome we can.
I'm going to let that be our final word. I want to thank you, Dr. Talk, for the incredible work you do, Dr. Lynn, for all the incredible work that you do. It's inspiring, and it helps so many people, and thanks again.
Thank you, Joe, for having us.
Thank you, Joe.
It's a pleasure. We have been talking to Dr. Robbie Talk. He is a cerebrovascular neurosurgeon at Mayo Clinic in Florida, and Dr. Michelle Lynn. She is a cerebrovascular neurologist. And they've been talking to us about stroke prevention and stroke survivorship. Well, that's our program for today. We hope you've enjoyed our show. If you missed anything, you can listen to the full episode at wjct.org and on your favorite podcast app. Thanks to all of our guests. Our executive producer is David Luckin. Stacey Bennett is our producer. Brady Coram is our director. Caden Collins and Caroline Kahn are our researchers. If you have questions about this or any topic, let us know by calling us at 904-358-6362. Email us at health@wjct.org or tag us on social media at @JSirven. I'm Dr. Joe Sirven, and you're listening to What's Health Got to Do with It on WJCT News 89.9 Jacksonville. Thank you for listening, and stay in touch.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation. Invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at AmericanBrainFoundation.org. Rethreaded needs you to make a difference in the lives of human trafficking survivors. Learn more about supportive services and an array of survivor-made products at rethreaded.com. And by Neurelis, a leading neuroscience company focused on the development and commercialization of therapeutics for the treatment of epilepsy and other neurologic disorders. The company's unique drug portfolios strive to address unmet needs in patient care. Learn more at Neurelis.com.